Imagine dealing with chronic pain. You know, that constant ache or throb that just wears you down, messes with your sleep, your mood, everything really.
It's incredibly common, unfortunately, and a lot of people turn to medication for help. Two you hear about a lot are gabapentin and pregabalin.
Exactly, those gabapentinoids, they're prescribed all the time.
They are, but there's this
Hmm.
this puzzle with gabapentin specifically that's bugged doctors for a while, which
Yeah.
is why does cranking up the dose often seem to, well, not do much more for the pain? It feels like it should, but often doesn't.
Hmm. Yeah, that sounds frustrating for everyone involved.
Meh.
Okay, so that's what we're tackling today in this deep dive, right? Gabapentin versus pregabalin.
Yep. We're going to dig into the latest research, the clinical insights, and try to pull out the key differences that really matter.
So you, our listeners, get the crucial takeaways without wading through all the complex studies. We want to understand what sets these two apart. Let's get into it.
Okay, so first, maybe a quick refresher on how they're supposed to work. Both of them target these specific calcium channels on nerve cells.
The voltage-gated ones.
Exactly. By binding there, they basically dial down the release of certain neurotransmitters like glutamate, substance P, the stuff that transmits pain signals.
So they sort of quiet down the overactive nerves. Same goal, basically.
Same basic mechanism, yes.
Yeah.
But how well they achieve that, and especially how reliably they get into your system to do it, that's where things diverge.
Okay. So this is where that dosing puzzle with gabapentin comes in.
Precisely. Gabapentin has this absorption problem. It gets saturated. We call it a ceiling effect.
Ceiling effect, meaning you hit a limit.
Yeah, exactly. Your body can only absorb so much gabapentin at one time from a specific part of the small intestine.
Wait, only the small intestine?
Primarily, yes. And once those transporters are full, which happens around, say, 600 milligrams in a single dose.
Which is about 1,800 milligrams a day if you take it 3 times.
Right. Once you hit that point, taking more doesn't mean more gets into your bloodstream. The absorption efficiency just tanks.
Tanks how much? Like, is it a small drop or?
Oh, it's pretty significant. We're
Yeah.
talking bioavailability dropping from maybe 60% at lower daily doses like 900 milligrams down to only about 33% if you're pushing up towards 3,600 milligrams a day.
Wow. Okay, so less than half is getting absorbed at those higher doses compared to lower ones. That really explains the ceiling.
It absolutely does. That 600 milligrams per dose, or 1,800 milligrams per day, seems to be the practical ceiling. Pushing beyond that is frankly unlikely to give you much, if any, added pain relief.
It's like pouring water into a funnel that can only handle so much flow.
That's a great analogy. The rest just sort of
Yeah.
spills over, doesn't get absorbed.
Okay, but pregabalin doesn't have this issue.
Nope. Complete contrast. Pregabalin maintains a really high, consistent bioavailability around 90% across its entire dose range. No saturation issues.
And why is that? Does it get absorbed differently?
It does. It uses different transporters and gets absorbed in both the small intestine and parts of the colon. So a much wider absorption window.
So no ceiling effect for pregabalin absorption. It just gets in reliably.
Pretty much, yeah. Which is a key difference in how predictably it works as you increase the dose.
Okay, so that's absorption. Big difference there. But what about once the drug is in the system? Is there a difference in, like, how hard they hit that target calcium channel, their punch?
Uh-huh. Another key difference. Pregabalin actually binds to that target, the alpha-2 delta subunit, about 6 times more strongly than gabapentin does.
6 times. Wow. So it's significantly more potent.
It is. That higher binding affinity translates directly to a greater effect at the nerve ending, a stronger dampening of those pain signals.
So better absorption and more potent binding. What does that actually mean for a patient feeling pain, faster relief, stronger relief?
Both, potentially. The combination means pregabalin tends to work faster. Its onset of action is usually around maybe 1.5 hours,
Compared to gabapentin.
which can take more like 4 or 5 hours to really kick in sometimes.
That's a huge difference if you're waiting for pain relief.
Absolutely. And studies often show faster reductions in pain scores with pregabalin because of these advantages.
This really changes the picture. It makes sense why clinicians might rethink their approach.
Yeah.
Let's talk about that shift. What was the old way of thinking?
Well, for a long time, if gabapentin wasn't cutting it at, say, 1,800 milligrams a day, the common practice was just to keep pushing the dose higher, 2,400, 3,000, even 3,600 milligrams a day.
Based on what? Older studies?
Yeah, older guidelines and some reviews, like an older Cochrane review, suggested potential benefit up to those doses, so people kept titrating up.
And cost was probably a big factor too, right? Gabapentin's been generic for ages.
Definitely. Gabapentin was and still is very inexpensive. A 300 milligram pill might be, what, 10, 11 cents? Pregabalin, before it went generic, was significantly more expensive, maybe 33 cents for a 75 milligram pill. So cost was a real barrier.
So doctors would stick with the cheaper option and just keep increasing the dose, even if maybe it wasn't doing much past a certain point.
That was often the pattern until clinicians started noticing, anecdotally.
Yeah, huh.
Moment. Kind of, yeah. Seeing patients on these really high doses of gabapentin, 3,600 milligrams, and they're still in significant pain, maybe getting more side effects, it made people ask, what's really going on here?
And then connecting that observation back to the pharmacokinetic data we just discussed.
Exactly. Realizing, oh, wait, maybe pushing the dose isn't helping because the drug isn't even getting absorbed properly. That really shifted the perspective.
So what's the updated approach? What I do now, so to speak.
Now, if a patient isn't getting good pain relief by the time they reach about 600 milligrams per dose or 1,800 milligrams total per day.
That ceiling dose.
Right. The thinking is, instead of pushing the gabapentin higher, it's probably time to reconsider. Maybe even deprescribe the gabapentin.
And consider switching.
And consider switching to pregabalin. Rather than escalating gabapentin further, trying pregabalin makes more pharmacological sense.
Is there a standard way to switch, like a conversion ratio?
Yeah, the generally suggested conversion is about 6-to-1. So 1,800 milligrams of gabapentin per day is roughly equivalent to 300 milligrams of pregabalin per day.
Okay, that's practical. And the cost issue now.
Much less of an issue, thankfully. Pregabalin is available generically now, so while maybe still a bit more than gabapentin, the cost difference is way smaller. It's much more accessible.
Good. So the evidence seems to point towards pregabalin having some advantages, pharmacologically.
Yeah.
What about clinical trials, comparing them head-to-head on efficacy and safety?
Well, direct head-to-head randomized trials are actually surprisingly scarce. That's a gap.
Really? For such common drugs?
Yeah. So a lot of the comparisons come from meta-analyses that pool data from various studies, often where each drug was compared to placebo.
Okay, so what do those analyses suggest?
Recent ones, like a 2022 analysis for post-herpetic neuralgia or shingles pain, found pregabalin seemed to provide superior pain control compared to gabapentin. Same for a 2021 analysis looking at spinal cord injury pain.
Superior how? Like better pain scores, better sleep?
Both, often. Better pain reduction, improved patient perception of how they were doing overall, sometimes better sleep quality reported.
But you mentioned older reviews like that 2015 Cochrane one sometimes showed similar effectiveness based on NNTs, number of pain needed to treat.
Right, but that's a crucial point. Those NNTs were comparing each drug individually against a placebo, not against each other directly.
Ah, okay. So you can't just look at the NNTs side by side and say they're equally good compared to each other?
Exactly. It doesn't work that way.
Yeah.
And even then, newer reviews, like an updated 2019 one for pregabalin, sometimes show slightly different results than the older ones, so the picture is always evolving.
Okay. What about safety? Side effects? Are they pretty similar?
Generally, yes. The side effect profiles overlap a lot. Dizziness, somnolence, or drowsiness, maybe some peripheral edema or swelling.
Any dose-related concerns?
Yeah, pushing pregabalin up towards its max dose, like 600 milligrams per day, does tend to increase the risk of those side effects, particularly the drowsiness and dizziness.
Are there any really serious safety warnings people should know about?
The main one that gets highlighted is the risk of respiratory depression, slowed breathing. It's considered relatively low risk if these drugs are taken alone, but the danger increases significantly if they're combined with other CNS depressants.
Like opioids or benzodiazepines?
Exactly. Combining them definitely raises a flag. And there's also been some recent observational data, not definitive proof yet, but suggesting potential links to increased cardiovascular risks or blood clots. So ongoing vigilance is needed.
It seems like even with all this information, there are still some gray areas or debates.
Oh, absolutely. For instance, not everyone agrees on exactly where gabapentin's ceiling dose lies. We've focused on 1,800 milligram a day, but some sources might suggest it's lower, maybe even 900 milligram a day.
No.
And also, while we've said pregabalin doesn't have an absorption ceiling, some researchers theorize it might have a different kind of ceiling effect at very high doses related to its mechanism, though that's less established than gabapentin's absorption issue.
So still some nuances being debated. And you mentioned the lack of direct head-to-head trials.
Right. That remains a significant gap. Clinicians are often making informed decisions based on pharmacology and indirect comparisons, but large direct comparison trials would be really valuable.
And cost, even with generics, can still be a factor in real-world practice.
For sure. Insurance coverage, formularies, patient copays, these things absolutely still influence prescribing and access, unfortunately.
Okay. So let's sort of bring this all together. The big takeaway from this deep dive seems to be really understanding that pharmacokinetic limitation of gabapentin, that ceiling effect.
Knowing that pushing gabapentin doses beyond about 1,800 milligrams a day is unlikely to yield more benefit because of how it's absorbed fundamentally changes the approach to treatment.
It gives you, the listener or your clinician, a clear point to say, okay, maybe escalating further isn't the answer here. Maybe it's time to consider the alternative.
Exactly. And knowing about pregabalin's more reliable absorption and higher potency and that 6.1 conversion ratio provides a logical next step if gabapentin isn't working well enough at that ceiling dose.
It's a powerful example of how digging into the why behind how a drug works, not just that it works, can really optimize how we use it.
Absolutely.
So the final thought for you to consider.
Yeah.
How does this specific example make you think about other areas? Are there other situations where understanding the underlying mechanism, the pharmacology of a situation, could challenge conventional wisdom or reveal hidden ceiling effects that limit effectiveness, whether in medicine, learning, or anywhere else? What assumptions might be worth questioning?